I'm Kirk Roberts. This is a fireside chat bringing AI from innovation to bedside. And really, my job here as a moderator is to play the role as a naive ivory tower academic who's completely clueless about how to bring the types of machine learning papers he publishes into actual clinical practice. It's not going to be a hard acting job for me. That's just the life I live. So I'm delighted to be able to listen to and learn from these distinguished panelists that we have. I will let them introduce themselves, so we'll start with just some brief introductions, as well as kind of maybe a good icebreaker is just a short success story and a short failure story. I think we've heard earlier today that it's important to be able to share some of the failure stories in AI because most stories are failures in this area, but we only really hear the successes. So Andrea, why don't you start off?
Great. Can you all hear me? Yeah? Okay. My name is Andy Cooley. I am a cardiothoracic surgeon by training, but am now with the UTHealth School of Medicine, which just opened a couple years ago out in East Texas. I've moved to the Assistant Dean of Clinical Experience role there and really have a passion for our region after working for 8 years in the clinical space in a very rural, underserved region. So we've been hearing a lot about rural and people that need access, and that's our wheelhouse. So the thing that's kind of striking to me is the difference between last year to this year in the symposium. Last year it was very much, look at everything we can do with AI. And this year it's, oh my God, look at everything we can do with AI. And it's turning a bit more into what is the responsibility of having that power and how do we roll it out safely and for everybody. I think what our next step is going to be next year is now that we have it where we're putting it in place, what do we do with the people it's for? So what do we do with the patients we find? What do we do with the frontline workforce and how they are managing everything, just to go with your question. So that's actually the success and the failure story I wanted to share of how things are going in Tyler. We don't have the resources to build these models and to build these extremely high-tech, amazing things, but what we do have is a way to look at how does it impact our population, how can we study it from a patient standpoint, from a workforce standpoint, from an economic sustainability standpoint, and really look at that implementation and sustainment model. How can we use AI that's already out there and other technologies to make that happen and make things accessible to everybody? So with that, we have a Healthcare from the Eye initiative, which is the new thing that launched out of this symposium last year. It's AI retinal scanning to identify diabetic retinopathy in the clinical primary care setting. Typically, diabetics should have a screening once a year. We have a screening rate at our pilot clinic, which is an FQHC of 0%, because we don't have cameras, and they're just told to go over to Walmart and get a scan or get an eye exam if they can, and they can't. So we launched this we have 20 days that we've had it in place. The other places that have launched this early, it's pretty much, we have 40, 50 patients over the course of 6 months. In 20 days, we've gotten 96 that had to get screened out of part of one clinic, and instead of the 5% rate of positivity we expect to see, we have a 30% rate of positivity, which means all of these people have to go on. So that's kind of the next point of where the failures happen. We find them and then can't treat them. So that is really what our research is. How do we actually leverage our data in the healthcare system and the support we now have as part of the university to be able to really change the healthcare system itself? Otherwise, it'll just end up another failure with all these things we try to roll out.
Great, thank you. Charlie.
Hi. This is working out good. It's a 0 or 1 on the bottom. I thought it was a 1, but it's, which I guess it is. Okay. So I'm a professor at UT Austin. I'm a professor in Department of Medicine at Del Med, and also a professor of computational engineering and science at the Odin Institute there. I just started in January, so I'm relatively new to Texas, in the process of moving here, just figuring out, damn, it's hot here, coming from Northern California. in the process of moving. But I started my career, I spent 14 years in the faculty at Stanford between the medical school and engineering school. And then 2010, I spun a technology out of my research lab to form a company that's called HeartFlow that does diagnostics, non-invasive diagnostics for heart disease. It's in about 1,200 hospitals now in the US, about 100 or so in Texas. 2014, we had FDA clearance when the first AI products cleared in that category in cardiology. 2018, Medicare. 2021, clinical practice guidelines. Also in England, it was the first AI product to be included in the MedTech funding mandate. Actually required, NHS hospitals were required to offer it. Went through that whole road. And it was incredibly exciting and, real passion project, really building a technology to improve the diagnosis of heart disease. On the failure side, I was thinking about this. I felt like I failed like every other month or so over that course of that journey. But I'll tell you, in doing this and taking a company out, taking technology out, starting a company, you are in different situations feel like you have these near-death experiences, these existential threats, whether it's a concern about cybersecurity or issues related to a clinical trial. And I will tell you, before we got FDA clearance, we actually missed the primary endpoint for our regulatory trial. That was incredibly painful. We ended up, having to, reduce the size of the workforce, kind of reboot, figure out what went wrong. Did another clinical trial, got through FDA, and again, many other challenges along the way. But it was, definitely a journey. Where, as I said, bringing technologies like this out into healthcare. All of the many challenges that are associated with that, I felt like we went through that. And I hope we talk about it today. I always say there's now over 1,000 AI products cleared by the FDA. I would estimate probably less than 10 of them are actually being paid for by Medicare in any measurable, any meaningful way. And I think one of the things we really have to figure out is obviously how to bring products into the healthcare system, fully integrated into healthcare, which means it's integrated into the healthcare payment systems, not just a cleared product that people don't get paid for it. If physicians and hospitals won't get paid for it, they're not going to really adopt it at scale, in my estimation.
Thank you. So I'm Edward Sacre. I was up here a little bit earlier. I'm an internist and the Chief Health Information Officer, Chief Value Officer at UTHealth San Antonio, and the chair of the UT AI Collaborative, along with my co-chair, the good Dr. McCaffrey over there. So I actually was going to have another question for you, because it's budget season now, and I'm wondering how Dr. McCaffrey got the funding for that. I was going to ask you, as president of the universities, what you're actually looking for in funding these initiatives, which is actually an interesting concept. From the successes that we've had, is your first question in AI, I'd say clearly the biggest one to date has been the ambient scribe. That's been revolutionary, a game changer, any other superlative or hyperbolic term you want to use, but really amazing. As a physician, I was talking a little bit earlier about this. Sometimes when we make a good diagnosis and help somebody get better, or they get out of the hospital, a family member will come by or a patient will come by and give you a hug and say, thank you for what you've done for me. I was at a get-together recently, and a cardiologist who used to spend his entire weekend doing notes from the week actually came up to me and gave me a hug and say, thank you for giving me this particular AI ambient scribe product. So it's a new position to be in. But again, a game changer. As far as what hasn't gone well, we've been pretty cautious in what we've done. So I don't think anything we haven't really failed on anything. I think the interesting area is, how do you measure the success of products? One of the things we implemented was the Epic message categorization, in-basket message categorization technology. And what that does is, when a patient sends an in-basket message, it automatically categorizes it, that it's a informational, that it's a medication request, that it's a clinical request, that it's a lab request, whatever, and then potentially you get it routed over to the right in-basket. And it's pretty complicated as far as the science. I have to ask the team over here, but SPICE and a few other types of models that I would need some education on. But what we found is that our team really doesn't have the expertise to fully understand what this is doing. And we've got really no way to understand how well this model's working. There's actually, Epic has two things that you can look at: how often somebody changes the categorized request, or if they decline what the categorized request is. So if they remove something or if they add something, but we don't quite know exactly how it works, and we think it's working pretty well. So I don't know if I don't think it's a failure. It's probably a success, but not completely sure what it's doing, which is an area why we want to get this group together. And I'd certainly have to second what everybody's been saying here. From last year to this year, and we've been talking about this quite a bit. This stuff is real now. It's no longer just fantasy, and that's how we coming together are going to leverage this to be successful.
Great, thanks. Yeah, I'm Dwayne Willett. I'm the Chief Health Information Officer at UT Southwestern in Dallas, cardiologist also. So yeah, appreciate the chance to be on the panel. In terms of success, just to not duplicate things, I would echo, although we're only in the pilot stage for ambient, it's clearly a win. I'll just add, we had some questions from patients about, from staff members who are patients about, do we have to disclose to them that we're using ambient? And the answer was, if your doctor's looking at you while you're visiting them, they're using ambient. So it's definitely been a win for patients too, I think. I would say the biggest users of actual clinical AI in our system are in imaging and radiology. And so one success story for us has been using that to prioritize the images that are read by our radiologists. They're in short supply, they're really busy, and been documented reduction in time to diagnoses of major events like intracranial hemorrhage and things like that, and even shortening time to treatment. So that's probably been a big success for us. And then on the failure side, well, not generative AI, we've done a number of predictive models, and it's not really a failure of the model, but a failure of it to do anything meaningful in the system. So where the actual prediction, getting that into workflow, never really worked. And so I think that's an ongoing challenge. We'll probably talk more about it, is how do we realize value from these that's actually valuable to our health system and to our patients.
Okay. So my next question, almost going to the topic of the bringing AI innovation to the bedside, sort of creates a timeline in my mind. And we're not just people who work in the healthcare space, we're also just general consumers of news. And so I'm sure the first time you heard about artificial intelligence, you weren't thinking about it purely from your job perspective, right? So we hear about things on the news, it's hyped, overhyped, overhyped. And I just want to kind of get a sense from your individual perspectives how you were thinking about AI before you fully realized that you would be sitting on a panel talking about AI in healthcare. So what was, just to level set, where were you in your thoughts about AI? And we can go with Andrea again and just go in order.
All right.
Yeah.
So starting out, I was I was at a medical simulation conference. So we were all sitting and we saw ChatGPT drop and we're like, oh, what's this? And it was an immediate, how do we apply it? So it's, we need resources, we have ideas, we just need something that can enable us to get from point A to where we need to go. So within 5 minutes of downloading it, I think we were already writing cases with it for teaching. And then basically it has turned us into what can it do next, and we just keep trying and seeing where it's going. So from our standpoint, it's an enabler for all the things we know we can do and all the things we want to do, and it just is an amplifier for our workforce. So from that perspective, excitement and just seeing where it can go each step of the way.
Charlie?
I just say that I've probably been using AI or building tools for about 30 years or so in trying to think about, we weren't talking as much about AI, we were talking about knowledge-based systems. The whole lexicon has changed over time, or expert systems. But I would say for me, the biggest profound impact that I had is that and this was, a couple of years after starting HeartFlow around 2011, 2012, we'd really built a pipeline to take medical image data, to do interpretation, basically a software system to use an automated algorithm, a visualization system, essentially a radiology workstation to do inspection correction of the automated models, and then those corrected models will get fed back into future generations of the technology. We started using traditional machine learning methods. But I remember, early on when we introduced the very first deep learning algorithm for image analysis or segmentation of the coronary boundaries, I was just struck by how much better it was than these kind of bespoke methods that we were using before, almost immediately. And then, feeding back with future generations of the software, it got better over time. We built this system. It's a human-in-the-loop AI system where there's about 250 people that work for HeartFlow that sit in front of a computer, look at a 3D model extracted from imaging, and then inspect and correct in the context of the image data, and then you can feed that back forward. But I was just really very pleasantly surprised at how good some of the methods got. I always say, in AI and in these methods, I always use Waymo as a great example of that, right? If Waymo, if they had people driving the vehicles around before they took people out of the driver's seat, and it's remarkable how fast that's progressed. But what they didn't do is put that in Boston and put Boston taxi drivers behind the wheel, because if they had done that, they would have taught it to drive like a Boston taxi driver. So I really learned the lesson about, obviously, it's the quality of the annotation, it's the process that you follow to annotate data, to curate data. It's not just big data, it's the quality of data that you feed back in that can make methods, remarkably good over time, in my experience.
Yeah, I would say from our standpoint, one of the key things has been looking also at and this is a big push, we had the return on the investment. This stuff can take a lot of money. And as we were looking at this, we know that, again, for the AI ambient scribe technology, that clearly is making physicians' lives better. Our motto at UTHealth San Antonio is make lives better, and part of it is to make the clinicians' lives better, and that's clearly making clinicians' lives better. As we're looking at these other products and the investment that we're making in platforms, whether a secure chat platform or a platform within Epic to do predictive algorithms and any future technologies that we're investing in, the question that we're always having to answer to the rest of our leadership is what that return on investment is going to be. Are we going to either improve efficiencies for clinicians, improve operational efficiencies, improve revenue cycle efficiencies, and improve clinical efficiencies? And those are all areas that we're really significantly looking at as we make an investment in these technologies.
Yeah, interesting thoughts. And just from a end user standpoint, trying things out at home, one thing that's really been impressive is the rate at which the models are improving. So, we all tried it out when ChatGPT first came, and it looked really cool. It's amazing it can write, and then you try to do things like have it generate, SNOMED codes or LOINC codes, and it's just making stuff up right and left. So it had kind of this impression, but with the reasoning models that have come out later and seeing the level, and then sort of the deeper research models, it's very, you start to be very impressed and think about almost like, how those could be used at work, even for sort of quasi-consultants, for example.
All right. So picking up on some of the things you've said so far, I'm reminded of the fact that, again, I'm the academic type who just publishes papers and hopes someone cares. And for years and years, no one did. And when I asked, what do I need to do in order to make these methods actually usable by people like you? And I'll have a couple questions about it, but one is just sort of the shock value of spending years asking, please do this, and now I almost feel like I need to say, please don't do this. It's almost like it went through not much adoption. I think Andrea sort of hinted this too. Oh, we're going to this maybe a little too fast. So I guess that's the first question. Are we going at it too fast? Or do you see it how is it from your perspective? We don't necessarily need to go in this order. So if someone feels very strongly about it, they can start off. And
You know, from our standpoint, one of the values of our AI collaborative is just that question there. You know, if we have models, we want to be able to categorize those models, understand what the performance is of those models, have they been successfully used? Because you're right, it's easy to, you know, see some new model, develop some new model internally, have somebody come with you with a new model to purchase because they say it's going to, you know, it's going to make categorization of patient risk better. It's going to make the, you know, categorization of who you should call better. But how do we really know that performance? And that is one of the things that we're trying to develop as part of the AI collaborative, is a central model repository where we're able to categorize just that. And I think we saw from Vanderbilt the Vamos example. There's other examples that we have out there, a few vendors. So I think that's a very important part of what we all do. And again, as part of UT system, if we're all beginning to implement some of these models, we can leverage what we're doing together to ensure that there's, one, appropriate initial vetting, that perhaps as Chai's talking about in training, you know, that we have a model card so that we understand what the model's performance is, how well it's been tested, fairness, all those other pieces before we implement it, and then monitor the implementation.
Yeah, and I'm going to make a distinction between sort of individual use, I think, and health system use, and when we're applying it to our patients. So as was said earlier, that there's a risk of us not actually using these enough and learning enough about them. So I think that's a risk that we see. And so from that standpoint, I'm happy to see the adoption and people learning how to use them. But I would share how these get evaluated for use in the health system. We sort of had good statistical methods, I felt like, for machine learning, and I would sort of defer to my colleagues up here who know more about this than me. But when you get into measurements and evaluation of generative AI, how exactly is that done? I know a lot of smart people are thinking about that, but I think that'll be helpful.
I'm not sure if we're going too fast. I think we have to recognize is an incredible difficult journey. I mean, for me, it was 15 years building one product in cardiology and bringing it all the way through. It takes time. I mean, it's difficult to do these things. I think there's so much opportunity in so many other areas of medicine, and I think it's just sometimes it can be overwhelming at kind of the magnitude of the problems or the opportunities. But I don't know if we're going too fast. I think, you know, I'll tell you, I'm really impressed by what has been done in the UK, because in the UK, obviously with DeepMind there, but they've really leaned on, the National Health Services really leaned in to really supporting AI across the board in their healthcare system. They've also really leaned in terms of making large data sets, aggregated large data sets available. You know, there was a study that was just done on my technology with 90,000 patients there. It was just completed, and you could do that in NHS England easily. They've done a good job of kind of collecting, collating, sharing that data. You could absolutely do that in the state of Texas, right? I mean, you could think about, obviously, as you, in an appropriate manner, I mean, having repositories, data repositories, appropriate de-identification, the way to get information out of it, because right now, the truth is, you can do this with the NHS, you know, UK Biobank, a lot of other data sources, but we don't really have, in my, at least my lens, a lot of opportunities to be able to do that in a research environment, to access large quantities of high-quality data in an, you know, appropriately safe, ethical manner.
And my thought is not too fast, with the caveat that we need to have the same speed with the other parts of the system. So right now we're very heavily focused on clinical and diagnostics, which is amazing, and we should be, but we also need to have the system as it relates to education, as it relates to the operationalization of it, of the cost of it, of, you know, we're talking about reimbursement and getting paid, but if your patients don't have insurance, that reimbursement doesn't matter. You know, so how do we build the system using these data sets, and how we can see those intersections between clinical and educational and economic in our data set together to make those decisions and those strategies and move those innovations along just as quickly as the diagnostic and clinical side are.
Okay. So another thing that was said that struck me, and Ed, I wrote down almost exactly after you said it, so hopefully I don't misquote you too bad, but you said what you don't have is someone who knows what the model is doing. And one of the reasons that was always told to me why you haven't, back in the day, in the Stone Age when these AI models weren't being integrated was, well, they make mistakes and we can't really explain it, and the model's like a black box and we don't really know what's going on. And if you guys just made it more explainable or interpretable, then we would probably be able to integrate it more easily. That was the story I was told. We are at a stage where the models that, as they are even less explainable and even more of a black box than they ever were. And yet here we are sort of going full speed ahead. So I guess to sort of throw the question back, not that you were the ones who told me this, but proverbially the people who told me that that was a barrier. Is the inaccessibility of these models, especially things like large language models that just, who knows what's going on? I mean, I'm a researcher. I've been working with large language models from the beginning. I have no idea what's going on in them. So how much is that going to be a barrier to their use?
Yeah, it's like being a good doctor. Just take this pill and it'll make you better. So the neural network, whatever it does, it'll make things better. I think the key piece of it is that we need to. You're right. We don't completely understand what it does. We understand the models that it was potentially trained on, or the data was trained on. I think these model cards and this categorization of how well it's worked in the training and validation, in the validation environments, and continuing to monitor for decay and deterioration of the model is what's going to be crucial. We've got to move quickly because we're at a time now where we really can make an impact relatively quickly with this technology, but it's incumbent on us. And there's a lot of barriers. There's legal barriers. There's legal folks at various organizations who don't want us to do a lot of this stuff because it's not completely understood. The governance isn't clear. Litigation against it's not clear. There's new legislation potentially coming out that may or may not impact it, but it's still incumbent on us to use the technology to move somewhat quickly. We just need to have a way to monitor how well the models work and be sure that the models that we've implemented have been adequately tested.
I think just a comment on that. I haven't brought a technology into different parts of the world also, and haven't looking at it through that lens. Recently, I think it was like a year ago, and it used to be you would go to bring a product into Europe, for instance, because the regulatory barriers were usually a little bit lower in the U.S. going through the FDA. But then what you realize is that the hard thing is not about getting clearance. It's about how do you integrate it into a healthcare system with the completely different payment models in every single country in Europe. It's really hard to do that. It's challenging. Last year, I think in the EU, they've obviously updated a lot of regulations, especially around AI, and they said, we want to be a regulatory superpower. I have to say, as somebody who has tried to bring a technology into a healthcare system, what that's going to lead to is actually very few companies that are going to bring that into that system. So I think we have to figure out how to do this in a safe, responsible manner, but let's not, in my opinion, don't go hard on from a regulatory perspective, because all that's going to do is that it's going to lead people developing the technology not to come to your area, to your region. So I think that's the right balance, to try to find how to do this in a responsible manner, but keep in mind that every action like that, the consequence of that action, in my estimation, in Europe, is that people will look at it, okay, all these other markets I could go to, I'm not going to go to Europe. I'm not going to bring these new technologies there if the barrier is too big to overcome. So we have to, I think, find some balance in that regard.
I think along with that is where, especially in this room, we have an immense opportunity looking at how this data can be put together across all of our different very heterogeneous practices, populations, and everything. Not only can we collaborate with each other, but that's where having data in real time, for the most part, where we can move very fast, make these insights, collaborate also with regulatory bodies to maybe not do things the same old way we did it when it was, okay, made this, tested it, a year later I'll give you the report. So we have opportunities to work with healthcare payers. We have opportunities to work with the FDA to really change that model, especially if we all work together in that. And then also have the sandbox idea. I mean, it could be a regulatory sandbox at some sites and really spin things up in a more of an agile framework to be able to do those things more quickly and in a new way.
Okay. So these models have also been referred to rather pejoratively as stochastic parrots, which is basically they're sort of repeating back things that they've heard and are very good at it, and they're still useful. But when that term was applied, the primary concern was that they were going to reflect the same biases and disparities that they were trained on, and especially when we get to models where we don't even know what's going on in them. So I don't think it's a controversial thing to ask. I like asking controversial things at panels because it just, but asking is bias a problem? We all know everyone's going to say, yes, we don't want that. So instead I'll ask, I mean, have you experienced, have you seen how this could happen in your own institutions, and how have you had to take any steps to mitigate it?
100%. I mean, I think that's part of the opportunity for rural, because in general they aren't getting health care, or they're being missed in a lot of places don't have Epic or Cerner, kind of the big EHRs. Like we said earlier, we're still faxing things, things like that. So the rural population in general, that's 70 million people in the US, is missing from these data sets, and it is a very different population. So we absolutely see some of that come out, and even some of the decision making, some of the tools, things like that, which, again, opportunity that we can change that.
Yeah, it's true that bias is very important. So, but we've had that before. In all of the medical studies that we've had, there's always been the risk of bias, whether it's coronary artery disease. that may have been studied in particular populations and people who are coming in for medical care. So it's something that we've been attuned to. We need to continue to be attuned to, but we also can't be and it's one of the great things about Texas is that we got the opportunity, especially as we collaborate across the systems, to have patients for validation across multiple different socioeconomic backgrounds. But we got a lot of people coming to us about bias. We as clinicians who've been involved both in research and trials and clinical care have always had that. So we need to keep our guard up, but we always should have kept our guard up for it.
Yeah, I would just comment is that obviously it's important. I think there's bigger issues, and I'll just use my own experience in kind of computer vision systems or AI systems for diagnostics and interpretation. I think there's a much bigger problem, to be blunt. 1,000 products have gotten cleared through the FDA. The bigger problem actually is most of those never get evaluated and tested. And you know why? Because you make if you never make a claim, you never say this product is to do this and provide this information, it's pretty easy to get a product, like a medical image interpretation algorithm, an AI algorithm through, because there's really not a lot of clinical data that is required, to evaluate it. I think we have the bigger problem, I think, is how do we kind of have robust way of evaluating some of these new products, whether it's the bias part of it or whether it's just do they work, in what context do they work. So I think that's, in my estimation, is a bigger problem that we probably don't talk enough about. I mean, a consequence is that you put a product out, is no claim based upon what the product does, there's no payment, there's no reimbursement, it's out there, it's in the wild, it's being used, and we just don't know how good it is.
Yeah, I would echo that, and that was right along the lines of what I was going to say. And I do think it's a subset of a bigger problem in terms of how well these models perform. The sort of traditional predictive models, we've had good statistical methods, so you could use that to track something over time for drift, and you could also use it to look at subpopulations to see if there was differences in outcome. How do you do that for the model that's probably the next big thing for clinical care after ambient, which is chart summarization? So how accurate was the summary of the patient's last 30 notes? And so there is some work around using other AI tools to automate the assessment of generated text and have that validated by humans. But we're going to need some kind of rapid cycle evaluation tool to be able to do these things.
But if you take that summarization, how are you going to judge the accuracy of summarization? And you're right, you may need some tool. Yeah, how would you
Yeah, so there's been some early work that was reported at the EPIC conference where they had human experts do it and assess it, and then they trained a model to against what the humans did, and came up with a scoring system and so on, and it, the performance was pretty good actually. So I think things like that are going to need to be done to sort of replicate human judgment.
And just to add, with the point about we're used to bias, I think right now AI is being held to a standard that's higher than our gold standard for it to be good enough. I mean, with the exceptions of things that are just thrown out there for product-wise. But I think kind of reframing that as well of what's the aim for where this one needs to be? Does it have to be perfect, or is it just looking to help in decision-making process versus replace? Yeah.
I just kind of perseverate on the chart summarization. So we're just piloting that now, and there's things in there that most of it's great, and your first impression is like, wow, this is amazing. But then you start somebody that actually knows the patient. You're like, well, this thing here, even though it's annotated, wasn't interpreted correctly. But again, as humans are doing chart, there's a lot of chart lore that gets carried forward, for note after note. We all know this. So we aren't going against the 100% gold standard to start with. Yeah.
One other quick comment I'd make about this is that, and this is an experience I had, is that when we brought a product forward, it was basically to do a non-invasive evaluation of coronary disease. You could go in the cath lab and do an invasive exam, angiography, pressure wire measurement, and test us whether we were right or wrong. And that's a challenge, right? But it was actually very helpful because, because we're regulated, when we got it wrong, when the physician went in the cath lab and there's a discordant result, they complained about it. We're required, because there's regulated, to do a systematic complaint investigation. That's a lot of work. But on the other hand, fast forward over time, you learn from those types of experiences. And I think to the extent that we implement these new tools, and we can have kind of critical feedback from the medical community into the people, whoever's developing it, that critical feedback will make it better. So it's incumbent upon us, quite frankly, when we're using these products, to complain if they don't work, to complain who's ever developing it, because that will be the mechanism to be able to make it better. But then it's also to hold the vendors, hold their feet to the fire and say, this is our expectation about the performance. You need to work on this. So you have a lot of control in the medical community about what the products look like that you're using.
Right. So you had asked, Charlie, what was a rhetorical question, and maybe you just, which was, how do we evaluate these?
Yeah.
And then we went on. I mean, is that? I kind of wanted you to answer your own question. I mean, is that the way you think we need to go about doing it, or what is that? I'm sure there are probably other types of models that.
I think it depends upon the model. I mean, it's different. I love that the technology, the ambient listening technology. I think it's amazing. To see that. So it depends upon the type of technology. How do you evaluate it? Again, my experience is more in radiology or visualization or diagnostic imaging. Then it's, what's your ground truth? Oftentimes in that setting, the ground truth is a physician interpretation, but they don't know any better reading a heavily calcified CT exam for a patient. They don't know any better than an algorithm knows. So you have to figure out, for that particular application, what are you going to do to try to find the ground truth? Seek the ground truth in that domain, and then, and that's what the FDA does, in some situations, products where you're making a claim about a diagnostic performance. If you're going to make that claim, you've got to prove that. You've got to provide it with clinical evidence.
So then help me understand, because when I write a machine learning paper and I evaluate a model, I have a ground truth to compare to as well. Now, it's something that's just sitting on it's data that's 5 years old and just sitting on a server somewhere. How is that different from than actually evaluating it with ground truth we're using the same words, but I have a feeling that it's a very different process, beyond just the FDA being involved.
Well, I think that one observation is it's very different what you do, even bringing a product through regulatory clearance and the level of a validation you do, or writing a paper, your training set, validation cohort, independent testing cohort. But what happens when it's in the wild? I think that's probably the questions those questions don't often get answered. And I think there's an opportunity from a UT system perspective to say, okay, we have these products, let's test them in the wild. Not a test run by the manufacturer, but a test run by a system to say, like, how does this work? How does it really work in our hands?
I think that's an opportunity for Train as well, with their pre-implementation, post-implementation testing, and then also having the registries available. That could be something more collaborative as it's really out there on that post-testing to see really how is it working and how can we look at that as a community.
Right, certainly the concept that we've had of the assurance labs, and one of the things that we've looked at potentially, do we as a system spin up a UT system assurance lab, and then again this model card where we are able to say what the initial performance is, performance over time, decay, all the other metrics that we're monitoring. So I think that's as we as a system look at doing collaboration, one of the areas, and certainly with Peter we've been talking about regularly is this concept of the assurance lab.
And this is, I think, another opportunity for us working together as a system. So in some cases, again, these kind of summarization models that we're putting in now, we can't really control the model. We're just using some public model that's being passed through. What we can control is the prompts that are sent to the model. And so as we have clinicians who are giving us real-world feedback about what's not, where it's getting it wrong, and we're adjusting prompts, again, the vision of being able to share that knowledge back and forth across our CMIO community and clinical informatics community and IT teams, I think affords a vision of being able to iterate on that more quickly.
It's always funny when AI topics sort of fall out of favor and come back into vogue. I was working on summarization 20 plus years ago, and for a good portion of the time since then, there was just no way to even publish a paper or get a grant on summarization, and now all of a sudden it's exploded all over again. So it's fun to see things come back like that. So I didn't want to get through this panel without sort of giving, maybe this is a bit dangerous to sort of ask the panelists to sort of come up with something, but we've heard about two big things have really come up in terms of the major areas of success, the ambient listening and as well as stuff with imaging. So what other areas do you see as really prime for success?
I think one of them is going to be the hands-free experience for clinicians. And we've talked about this, being able to walk into a room, whether it's an exam room in the hospital or an exam room in your clinic, and have a hands-free experience. You've got a microphone there, you've got an ambient platform, you've got clinical decision support powered by AI, and you've got the ability to tee up orders and help you with predictions for the future, for care for the patient. That's clearly, we've gotten to the point where that's a reality. So I think that's what we see in the next few years, and potentially combining that with some of the virtual care platforms that you can be bringing in family members who aren't able to be present. You can bring in other expert physicians. That technology is finally beginning to coalesce. I think that's one future that we're going to see within the next few years.
Yeah, I agree. I think there'll be a lot of work just on the operations of the health system. So we have a lot of challenges getting the right patients into the right specialists, and to benefit the health of Texans in general. So ways to automate that and do that smarter, I think will be a big thing. And then hopefully this may take more than 5 years, but again, as these technologies can give clinicians better situational awareness, the ultimate goal would be that we can decrease medical errors. I think that's, or not the ultimate goal, but that'd be something I hope to see.
So I know you all know I'll say systems approach, access to care. But the other thing, I think anytime we say patient, we can also say student. So we can use all of these things, twist a little bit of how we're applying this technology, and have precision education for our students as well.
Yeah, just maybe close with a thought. I remember 30 years ago, I went to a conference present the idea of combining imaging and computing for heart disease, doing patient-specific modeling. And at that conference, somebody was given a talk 30 years ago. Is the internet a big deal? Is it a big deal? Is it like fire, or is it a smaller development in human history? You could say exactly the same thing about AI. And I think fast forward 5 years from now, I think there's so many opportunities for use this in a very constructive way. And I think there's a multitude of great problems. I'm really interested about being able to predict prognosis and risk for patients based upon existing data. What will happen if you follow this time course, trying to understand progression or regression of human disease in the areas that I work in.
I think that is the perfect way to bring a conclusion to this panel. Thank you so much, Charlie. So please, everyone, give a round of applause for our great panel.